Hi, I'm going to do a video with you on bandaging today. Stages of wound healing. Let's start there. 4 stages of wound healing: inflammation, debridement, repair, maturation. You can remember them in order with the IDRM. I remember it as I don't recommend meatballs. One of my other students remembered it as it doesn't really matter, but it does. So inflammation, debridement, repair, maturation. Inflammation starts right away. Maturation can take years. With horses, they have this granulation tissue called proud flesh. So things develop a little bit differently in horses in some instances. You also have first, second, and third intention healing. First intention healing means there's a wound, you sew it closed. That's first intention. Second intention means you're not going to sew it closed. You're going to allow it to granulate in. So think of it like a deep, crevice or something. It's going to fill from the bottom up with tissue. Okay. That tissue is called granulation tissue. That's what's called proud flesh in horses. It's that proliferation collagen phase. Third intention healing is when you wait 4 or 5 days and then you surgically close it. So this could be an animal is hit by a car and dragged for a while and they've got road rash all up their leg or something. There's too much there to debride any other way than to do this. So we'll wait 3, 4, 5 days. Let it kind of debride on its own, and then we'll close up any remaining places. Sometimes when we close it, we use one of these. This is called a Penrose drain. It's got a hole in the middle, if you can see there. When we put these in, we pinch it like this and sew it into place. So if I had a big wound here, and the doctor just sewed it closed, if it's this deep wound and the doctor sewed it closed, I can have an abscess form, I can have a seroma form, all kinds of things. So they're going to put this in. So they sew it into place. They sew my skin closed over it, and then they'll cut the ends of it, but they'll sew it into place like this. It leaves it open just enough. Nothing goes through the middle of it. It just trails along it and drips off the end. So it stays there for 3 to 5 days. Just like that, dripping off. And clients don't usually like this because it drips all over their house. We usually tell them, put a t-shirt on them. You can't bandage it up because you don't want it to be closed. That's why we have a drain in. 3 to 5 days, snip the sutures holding this, and then they'll just pull this out, just take the drain out and leave it. And the other sutures are holding the entire thing closed, so it'll close up there as well. So 3 to 5 days, take out your Penrose, 10 to 14 days to take out your sutures. Now, bandage materials, different types of materials and different types of bandages. A Robert Jones bandage is a very thick, very padded bandage that can only be done on the lower limbs, so lower front legs, lower back legs, because you have to include the joint above and the joint below it. It's to stabilize a fracture. So if I have a fractured radius or ulna, look at all the motion that those bones will have. So I have to stabilize from here all the way up to here so that I can't twist these joints and move those bones around. So Robert Jones is going to be similar to the one that I'm doing. I'm going to do a modified Robert Jones to show you. The difference is modified Robert Jones, we typically do these post-op. So we are providing comfort for the patient. We are also providing some protection for that wound, and we're providing somewhere for the wound's natural exudate to absorb. Sometimes you'll find this at your practice, Manuka honey. If you see Manuka honey, the reason is because every once in a while we'll use this on very badly damaged tissues, if there's a wide area especially. Manuka honey has natural antibiotic properties, natural anti-inflammatory properties, and it helps build up that granulation tissue. So if you see this around your practice, that is why. Don't use it for your lunch. Okay, let's bandage this guy. So this is my patient. I'm going to bandage his leg. I'm going to do a modified Robert Jones. Let's see if I can turn him here. There we go. So the first layer, my primary layer, is a Telfa pad. It's shiny and slippery. Think of Telfa like Teflon. I put this on first. Let me actually back up. I'm going to do stirrups first. My stirrups are 1-inch porous tape. Tear it off, tab both ends. Just a little tab. Put it on like this. Make sure it's good and stuck down. Do your second stirrup, same way. These stirrups prevent the bandage from slipping, and you'll see how in just a little bit here. So I stick it to my leg, and then I got to have something between these so they don't stick to each other. I'm just going to use my pen. Typically use a tongue depressor, but I forgot mine. Okay, next, I've got my Telfa pad. Then I use stretch gauze for my secondary layer. It's very stretchy, and unroll it like this so that you can just roll it around the leg instead of going underneath and trying to kind of fumble it. You have to wrap from distal to proximal so you don't trap fluids in the leg or in the foot. When I'm unrolling this, I want to overlap by half each time, and I'm not doing it tight. I'm just placing it on the leg. Make sure that you cover your stirrups. If they still stick out the top, you can just cut off that little bit. Okay, so that's enough of that. Next comes the cast padding. Cast padding is very floofy and it just kind of tears like that. So again, distal to proximal. Make sure that you don't have lumps and bumps under here because those can cause decubital ulcers. You might have heard the common term bed sores or pressure sores. It's sort of like a pebble in your shoe. If you have a fold of this stuff, it's very fuzzy. If you have a fold of this stuff, it can cause one of those pressure sores. So there's my secondary layer done. Both of those things together make your secondary layer. Now I need to reflect my stirrups. What that means is I'm going to take this off. The sticky side is over here. This is the non-sticky side. I need to twist it at the base and stick it up here to the bandage. This keeps the bandage from slipping down because it's stuck to the leg underneath there. So I twist this side, put it on. All right, I'm in good shape. Now, tertiary layer. The tertiary layer is made from vet wrap. In human medicine, they call this Coban, and it's usually like a beige color. In veterinary medicine, we get fun colors. Vet wrap is very easy to make too tight because it is stretchy. So what we do is we back roll it. That means take a whole bunch off and then roll it back up so that when you unwind it on the patient, it's not too tight. Okay, so again, distal to proximal, and notice how I'm leaving some of the white out. I want to leave just a tiny bit of white out because this stuff sticks to fur and it'll kind of pull their hair. I'm also leaving the toes out on purpose. I'll tell you why in just a sec. Now with vet wrap, one of the things that we do in veterinary medicine, they don't do it in human medicine, which is kind of a shame. We do vet wrap art, which sounds silly, but it's just a nice gesture. We'll take a little bit of vet wrap in a different color and we will cut a heart out of it or a flower or something like that, and we'll just stick it on top of this bandage. The clients like it. It makes it seem like we put a little bit of extra effort in, and it only takes a second to do. So when I finish this, I want to finish it on the back side so there's nothing for the dog to sit there and grab with their teeth. So here's my bandage. Now sometimes we will also use a piece of this. This is called elasticon. It's weird. It only sticks when you don't want it to. It can't be torn. It's like, it feels like fabric on one side and this weird gooey sticky on the other. It looks like this. So with the elasticon, we go at the top like that. It just helps the bandage keep it from slipping. Now, one thing that we'll do a lot of times is, because they're going to be shaved before you put this bandage on, this doesn't go on over fur because they had a wound or something, so we shaved them. What we'll do a lot of times is we'll take a Sharpie and we'll draw a line right at the top of the bandage. So when we discharge the patient, we're going to give them some pieces of advice. We're going to tell them at least twice a day, check this bandage, make sure it is dry, watch for swelling above or below the bandage. Feel the toes. That's why you leave them out. Feel the toes. If they're cold, it might mean that something got pinched off in here and we need to take this bandage off. So feel the toes for coldness and check for slipping. You can look at that line. We tell them if it slips more than about this, come back in and we need to replace it. Other times we need to replace the bandage. If this is an infected wound, we need to replace it daily. If this is just a healing wound, like from surgery, there's an incision under here, we need to change it every 3 to 4 days. And if this is just a regular, either type of bandage, and you see strike through, if there's visible strike through, that means you can see something seeping, something wet under there, then we need to change it then as well, okay? When you take bandages off, of course you'll need a bandage scissor. They look like this. And it's got like that nubbin on one end, so that when you slide this down the leg to cut it off, you're not cutting them with the point of your scissor. So you have to use a bandage scissor. You will need to cut the layers separately, especially with a Robert Jones bandage. Robert Jones bandage is put on the same way, except instead of that cast padding layer, you use roll cotton, which is about this thick. So it's that much thicker all the way around. Because remember, it's to stabilize so they can't bend and twist. So you have to use a bandage scissor and cut the layers separately, cutting from proximal to distal. Never cut up on a bandage, because you can cut right between the toes without even knowing it. So use a bandage scissor, cut the layers separately from proximal to distal. Also, make sure there's no body parts in the way, like what I was just telling you. And don't cut over the incision. So my incision was right here. I can't cut this way. I'll have to come from underneath and cut from the back of the bandage. All right. When you clean these kinds of wounds up, you're going to be using something probably called chlorhexidine. Chlorhexidine can come, it's either blue, it's usually blue, sometimes it's pink depending on what brand you get. It has to be diluted. If you use chlorhexidine or you use betadine, betadine is the one that's more orangey brown. It's an iodine-based product. Both of them must be diluted. Don't use them straight. Ointment, don't put any ointment on there unless your doctor tells you to. We usually don't use ointment. Other things that we can put on these bodies, we can put on a Velpo sling, an Emer sling, or some splints. A Velpo sling is for the front leg. We flex the wrist, flex the elbow, and flex the shoulder, and we bandage it this way so that they are non-weight bearing on their front leg. That it holds their leg up, so they have to only use the one leg to walk. That's a Velpo sling. I remember that one's Velpo because the arm makes a V. An Emer sling is the back leg, where you flex the knee, the hock, and you bandage it that way. It's just one piece of tape that goes all the way around, holding their foot in that position so they're non-weight bearing on that back foot. So say, for instance, they had a hip dislocated or a shoulder dislocated, you put it back in place, and then you do one of those slings so that they can't be walking on it, because those tissues need to heal up or they're just going to dislocate again. Other things that you can use. These are splints. This one is called a spoon splint, and it looks like this. It's a green hard plastic with kind of a beigey yellow foam. These come in different sizes, and they have these lines for breaking them. So it depends on how long your patient's limb is. And it would go like this. All right. So you would just measure it to length, and it would be incorporated in with your bandage in your secondary layer. So that's a spoon splint. Then we have quick splints that look like this. These are for a left front and a left hind leg, and you can tell by the way they're shaped. Front leg versus hind leg. These are for left side because they're cupped that way. They also have them for right side because they don't work interchangeably. So there's that type of splint as well. Lastly, head wraps. If you're going to do a head wrap on a patient, say for instance you did an ear canal ablation or a hematoma repair, you have to fold the ear back and bandage it that way so that you don't trap moisture and stuff inside the ear canal. And with all things, before they get closed up, you want to make sure that there's no infection. If there's a wound that's infected and you close it up, you can cause what's known as dehiscence. If the doctor sutures it up too soon. Dehiscence is when the tissues and everything just kind of falls apart. The sutures don't hold, they just fall apart. So that's dehiscence, Dehiscence. Okay, that is all things bandages. Oh, there is one more thing actually. This is called stockinette. Stockinette works just like a sock, and it goes on like this. If you can see that. And then we would put a cast on over it. We really don't cast things in veterinary medicine. We do bandages, we do splints. We usually just do surgery. If they've got a broken bone, we'll pin it, we'll plate it, we'll screw it together, we'll use cerclage wire, we'll do something like that instead of just putting on a cast for so many weeks. It just doesn't work as well in animals. Okay, that is all things bandaging.